All right, take a quick breath. Section 1. Classic neurological tumor presentations. Get your eyes ready to read along with me as we meticulously walk through these classical textbook presentations.
These are the foundational associations you simply have to know. Look at this first row. Classical presentation, progressive unilateral hearing loss, plus tinnitus, plus imbalance. Tumor, vestibular schwannoma, or acoustic neuroma. Why it's classic? CN8 involvement. It's a cerebellopontine angle tumor. Next up, classical presentation, bitemporal hemianopia plus endocrine dysfunction. Tumor, pituitary adenoma. Why it's classic? Compression of optic chiasm. Moving down, classical presentation, child with short stature plus visual loss plus diabetes insipidus. Tumor, craniopharyngioma. Why it's classic? Supercellular tumor affecting pituitary stalk. And the last one here, classical presentation, personality change plus asthenia with or without ipsilateral optic atrophy and contralateral papilledema, which is Foster-Kennedy syndrome. Tumor, olfactory groove meningioma. Why it's classic? Frontal base meningioma. Really let those sink in.
Now, what's really interesting about this next batch is the contrasting timelines we're going to see. Let's go through it. Classical presentation, rapidly progressive focal deficit, plus a ring-enhancing lesion crossing the corpus callosum, the quote-unquote butterfly lesion. Tumor, glioblastoma multiforme, or GBM. Why it's classic? Most common primary malignant brain tumor in adults. Contrast that rapid timeline with the next row. Classical presentation, young patient with long history of seizures. Tumor, low-grade diffuse astrocytoma. Why it's classic? Seizures are often the first presenting symptom. See that difference? Okay, next. Classical presentation, ipsilateral ataxia, dysmetria, intention tremor. Tumor, cerebellar tumor. Why it's classic? Cerebellar hemisphere lesion. And finally, classical presentation, cranial nerve palsy with contralateral hemiparesis, known as crossed signs. Tumor, brainstem glioma. Why it's classic? Brainstem involvement.
All right, continuing on. Classical presentation, multiple brain lesions in a patient with lung/breast cancer. Tumor, brain metastases. Why it's classic? Most common brain tumors overall. Next one. Classical presentation, headache, plus seizures, plus a slow-growing extraaxial mass with hyperostosis. Tumor, meningioma. Why it's classic? Common benign tumor in middle-aged women. Now notice this next one. Meningioma repeats, but the exact location dictates the specific deficit. Classical presentation, leg weakness greater than arm weakness, plus parasagittal mass. Tumor, parasagittal meningioma. Why it's classic? Compression of medial motor cortex, specifically the leg area. And the last one in this section, classical presentation, complex partial seizures plus superior quadrantinopia, quote, pie in the sky, unquote. Tumor, temporal lobe glioma. Why it's classic? Involvement of Meyer's loop.
Section 2. Syndromes every examiner likes. So, shake it out, take a deep breath. We're shifting from isolated presentations into grouped clinical signs. And let me tell you, examiners absolutely love testing these exact syndromes.
So, the crucial point is that you have to recognize these symptom clusters instantly. First up, Foster-Kennedy syndrome. Tumor, olfactory groove meningioma. Detailed clinical signs, anosmia, ipsilateral optic atrophy, contralateral papilledema. Next, cerebellopontine angle syndrome, usually due to vestibular schwannoma. Detailed clinical signs, progressive unilateral sensorineural hearing loss, tinnitus, vertigo/imbalance, absent corneal reflex representing CN5, and facial weakness representing CN7, which is late. Now notice how vestibular schwannoma is a real frequent flyer in this explainer? As it grows, it just adds those cranial nerve 5 and 7 signs right into the mix.
Let's keep going. Chiasmal syndrome, usually due to pituitary adenoma. Detailed clinical signs, bitemporal hemianopia, headache, endocrine abnormalities. Next up, raised intracranial pressure, or ICP syndrome, seen with many intracranial tumors. Detailed clinical signs, morning headache, projectile vomiting, papilloedema, sixth nerve palsy, reduced consciousness, which is late. Let those words lock in. They are vital.
All right, moving right along. Section 3, high-yield buzzword associations. We're going to pick up the pace a bit here because these buzzwords, they're literally the ultimate cheat codes for rapid pattern recognition in any exam. Let's rapid fire this. Buzzword, butterfly lesion. Diagnosis, glioblastoma. Buzzword, popcorn lesion. Diagnosis, cavernous malformation. Buzzword, dural tail. Diagnosis, meningioma. Buzzword, Hyperostosis of skull. Diagnosis, meningioma. See how brilliantly that illustrates how often meningiomas show up? Okay. Buzzword, cerebellopontine angle tumor. Diagnosis, vestibular schwannoma. Another massive repeat right there. Buzzword, optic chiasm compression. Diagnosis, pituitary adenoma.
Keeping that energetic pace going. Buzzword, child plus calcified suprasellar cyst. Diagnosis, craniopharyngioma. Buzzword, ring-enhancing necrotic mass. Diagnosis, glioblastoma. Buzzword, multiple enhancing lesions. Diagnosis, metastases. Buzzword, long history of epilepsy. Diagnosis, low-grade astrocytoma. Buzzword, crossing the midline via corpus callosum. Diagnosis, glioblastoma. I mean, look at that. Notice how glioblastoma completely dominates when it comes to the aggressive, destructive buzzwords like necrotic and crossing the midline.
Okay, Section 4, must-know tumor one-liners. Time for the absolute, non-negotiable, must-know one-liners. This is where statistical prevalence is literally everything.
You need to pay extreme attention to the qualifiers here. Words like overall, primary, malignant, and benign. Do not let them trick you. Let's read through carefully. Description: most common brain tumor overall. Diagnosis: metastatic brain tumor. Description: most common primary brain tumor overall. Diagnosis: meningioma. See the difference? Okay, description: most common primary malignant brain tumor in adults. Diagnosis: glioblastoma multiforme, or GBM. Description: most common benign intracranial tumor. Diagnosis: meningioma. Description: most common cerebellopontine angle tumor. Diagnosis: vestibular schwannoma. Description: most common pituitary tumor. Diagnosis: pituitary adenoma. Description: most common pediatric suprasellar tumor. Diagnosis: craniopharyngioma.
Section 5, 30-second Viva revision. Buckle up, everybody. Let's move to and see how this builds into our final high-speed matching sequence. This is specifically designed to test your immediate recall, right here, right now.
I'm going to act as your enthusiastic examiner. Let's drill this. Presentation, hearing loss plus tinnitus. Diagnosis, vestibular schwannoma. Presentation, bitemporal hemianopia plus endocrine symptoms. Diagnosis, pituitary adenoma. Presentation, child plus DI plus visual loss. Diagnosis, craniopharyngioma. Presentation, anosmia plus Foster-Kennedy syndrome. Diagnosis, olfactory groove meningioma. Presentation, butterfly lesion. Diagnosis, glioblastoma. Presentation, long-standing seizures in the young patient. Diagnosis, low-grade astrocytoma.
Don't stop. Keep that high-speed energy going. Presentation, ipsilateral cerebellar signs. Diagnosis, cerebellar tumor. Presentation, crossed cranial nerve deficits. Diagnosis, brainstem glioma. Presentation, multiple brain lesions. Diagnosis, metastases. Presentation, dural tail plus hyperostosis. Diagnosis, meningioma. Presentation, leg greater than arm weakness. Diagnosis, parasagittal meningioma. Presentation, pie in the sky. Diagnosis, temporal lobe glioma. Boom. Amazing job making it through that incredibly comprehensive 30-second cram session.
So I want to leave you with this provocative...
Section 1, the basics of ICP. Let's establish the exact parameters of our pressure cooker. Okay, let's get our definitions straight right off the bat. Intracranial pressure, or ICP, is the pressure exerted by the contents of the cranial cavity, and by that we mean the brain, blood, and cerebrospinal fluid. We define intracranial hypertension as a persistent pressure greater than 20 to 22 millimeters of mercury that requires treatment. Now, the baseline we must all absolutely memorize is 5 to 15 millimeters of mercury. You need to lock that specific number in for the wards. Anything persistently above 20 to 22, that's where our alarms need to start ringing. Pay close attention here, because this is a massive board favorite. The Monroe-Kelly doctrine explains the delicate balance inside the skull. Let's look at the components. The brain makes up roughly 80% of this space, with CSF at about 10% and blood taking up the final 10%. The core principle here is that the skull is rigid and fixed volume. So what does that mean for us? It means an increase in one component must be compensated by a decrease in others, or ICP rises. It's really just basic physics applied to the human head.
Section 2, causes and cerebral edema. What exactly happens when that perfectly fixed volume is compromised and the whole ecosystem breaks down?
When this ecosystem breaks down, the culprits generally fall into 3 distinct categories. First, we have increased brain volume. This can be driven by a brain tumor, cerebral edema, cerebral infarction, encephalitis, or a brain abscess. Next up, increased CSF volume. This might stem from hydrocephalus, obstructed CSF pathways, or meningitis. And finally, increased blood volume. This is typically caused by intracerebral hemorrhage, subarachnoid hemorrhage, venous sinus thrombosis, or hypercapnia leading to vasodilation. Looking specifically at cerebral edema, we see 3 different types, and knowing the difference is an absolute game changer. Vasogenic edema involves blood-brain barrier disruption, which is commonly seen in tumors and abscesses, and crucially, steroids are effective here. In contrast, cytotoxic edema involves cellular swelling from stroke or hypoxia, and here, steroids are not effective. Finally, interstitial edema happens due to hydrocephalus, as CSF leaks right into the brain parenchyma. Section 3, Clinical Features and Herniation. This is where the rising pressure manifests clinically, and those terrifying warning signs of impending doom actually start to appear. Tracing the progression of these clinical features is so critical. For symptoms, patients typically present with a headache that is worse in the morning, projectile vomiting, blurred vision, diplopia, altered consciousness, and seizures. When you examine them, early signs reveal papilledema, a sixth nerve, or CNV, palsy, confusion, and drowsiness. But if those are ignored, critical late signs develop. Cushing's triad, pupillary changes, decerebrate or decorticate posturing, and ultimately coma. All right, let's dive into this favorite Viva. Cushing's triad is an absolute emergency. It signals impending brain herniation. The triad consists of: number 1, hypertension, specifically with a widened pulse pressure. Number 2, bradycardia. And number 3, irregular respirations. If you see these 3 together, time is literally running out. Because if that pressure isn't relieved, the brain physically shifts. This is brain herniation. Uncal or transtentorial herniation causes an ipsilateral dilated fixed pupil via CN3 compression, alongside contralateral hemiparesis and reduced consciousness. Central herniation is characterized by progressive coma, bilateral small, then fixed pupils, and abnormal respiration. Tonsillar herniation? Incredibly dangerous. It causes medulla compression that leads to respiratory or cardiac arrest and is often fatal. Finally, subfalcine herniation compresses the anterior cerebral artery, which presents as leg weakness. Section 4, Investigations and ICP Monitoring. How exactly do we urgently visualize and measure this escalating crisis? For investigations, a CT brain is your first-line emergency step. It can show a mass lesion, a midline shift, hydrocephalus, effaced ventricles, loss of Sulci, and cerebral edema. An MRI brain gives you better soft tissue detail and is incredibly useful for tumors and posterior fossa lesions, but the CT is always your initial go-to. Now for ICP monitoring, the gold standard is the intraventricular catheter, or EVD. It measures accurately and actively allows for CSF drainage. We also have other devices, namely the intraparenchymal monitor, the subdural monitor, and the epidural monitor. Though it's definitely worth noting the epidural monitor is the least accurate of the bunch. Section 5, Management and Complications. This is the urgent resolution phase where we actually step in to relieve the pressure. So, how do we manage it? Initial measures focus strictly on ABC stabilization, oxygenation, maintaining BP, and treating the underlying cause. Alongside this, general measures are absolutely vital. Elevate the head to 30 degrees, keep the neck neutral, ensure proper analgesia and sedation, avoid fever, control seizures, and maintain normal capnia with a PaCO2 target of 35 to 40 millimeters of mercury. For medical treatment, we rely heavily on osmotherapy via mannitol or hypertonic saline. We use dexamethasone strictly for vasogenic tumors only. We also utilize EVD drainage, and we can use hyperventilation as a temporary rescue to lower PaCO2. Surgically speaking, we're looking at interventions like a decompressive craniectomy, hematoma evacuation, tumor excision, a VP shunt, or placing an EVD. If we fail to manage this properly, the reality is incredibly grim. The complications of raised ICP include brain herniation, brainstem compression, permanent neurological deficits, blindness resulting from chronic papilledema, and ultimately death. Section 6, Rapid Revision and Viva. Let's shake off the heavy reality of those complications and lock in everything we've just learned. It is time for the masterclass wrap-up. Snap your attention right back here, guys. We are going into a rapid-fire testing sequence. What are the absolute must-know IMM and FCPS favorite Viva questions for your board exams? Let's hit them. Let's rapid-fire the most testable facts. Normal ICP? That's 5 to 15. The Monroe-Kelly doctrine? Fixed volume balance. Most accurate monitor? The EVD.
Your earliest CN palsy, CN6. The classical triad is headache, vomiting, and papilledema. Do not confuse that with Cushing's triad, which is HTN, bradycardia, and irregular resp. And steroids? Remember, use them for vasogenic edema only.
Now, what's really amazing about this is it's basically your entire study guide. Let's complete our zero omission goal with a 60-second rapid revision. Normal ICP is 5 to 15. Raised ICP is greater than 20 to 22. The Monroe-Kelly formula dictates that fixed volume. Earliest CN palsy is CN6. Classic symptoms are your morning headache, vomiting, and vision changes. Classic sign is papilloedema. Impending herniation shows as Cushing's triad. Your first imaging is a CT brain. The gold standard monitor is the EVD. The best osmotic agents are mannitol and hypertonic saline. Use steroid only for vasogenic edema. And finally, definitive treatment always means fixing the underlying cause.
To the overarching rules for size, because this literally dictates our entire strategy.
When it comes to submandibular stones, size is everything. For stones less than 4 millimeters, your preferred management is conservative treatment, with or without endoscopy retrieval. Now, if we bump up to that 4 to 7 millimeter range, things change a bit. Here you're looking at endoscopy-assisted removal or a transoral duct surgery, which is known as a ductotomy. And for the big ones, anything over 7 millimeters calls for transoral surgical removal, if it's palpable. If it's inaccessible, though, you're looking at a combined approach or even total gland excision.
Moving right along to Section 2, Distal Wharton's duct stones.
Location matters just as much as size, right? So for stones located in the anterior floor of the mouth, the distal duct, we adjust our tactics. If that distal stone is under 4 millimeters, you're going to start with hydration and silagogues. Think lemon drops. You'll also want to incorporate gland massage, sometimes called milking, along with NSAIDs. If the gland happens to be infected, definitely add antibiotics to the mix. And if the stone is still persistent after all of that, you proceed to silendoscopy.
What if that distal stone is mid-sized, say between 4 and 7 millimeters? In that case, you'll use endoscopic retrieval, typically utilizing a basket or forceps, or you can perform a transoral ductotomy if the stone is actually palpable. For the larger stones, anything over 7 millimeters, the pathway requires a transoral ductotomy with stone extraction, followed by marsupialization of the duct if required.
Next up, Section 3, hilar and intraglandular stones. We're shifting our focus deeper into the proximal anatomy now.
First things first, let's orient ourselves geographically. We are targeting the area near the hilum, right around the second molar region. Lock this into your brain because this is a classical FCPS viva site.
So let's break down these hilar calaire, or proximal duct stones. If it's small, meaning under 4 millimeters, silendoscopy is indicated. For a 4 to 7 millimeter stone, you'll want to employ silendoscopy-assisted transoral removal, or a combined endoscopic and open transoral approach. Now, for the large ones, over 7 millimeters, you need transoral hilar stone removal by an experienced surgeon, assuming it's palpable. But if that stone is deeply embedded or just not palpable, you're ultimately heading towards submandibular gland excision.
Going even deeper into the gland, we find intraglandular stones. If they're small and asymptomatic, observation is perfectly fine. Just keep an eye on it. However, if they become symptomatic or they start causing recurrent infection, submandibular gland excision becomes necessary. As a quick caveat for specialized care, silendoscopy-assisted techniques might actually be used for specific cases, but typically only in selected specialized centers.
All right, Section 4, Managing Acute Sialadenitis. We need to talk about this before we even think about definitive removal. Listen, you absolutely cannot dive into removal if the gland is acutely inflamed. You have to treat the infection first. The strict protocol here is antibiotics, hydration, massage, silagogues, and analgesia. Don't skip any of these.
And that brings us to this absolutely crucial clinical rule. Definitive stone removal is performed after the acute infection settles unless urgent drainage is required. Seriously, let that sequence completely lock into your memory.
Section 5, the Viva flowchart. Let's map everything we just learned out visually.
Imagine your mental flowchart. When you identify a submandibular stone, step 1 is to immediately assess its size and location. If it's less than 4 millimeters, your treatment path branches to conservative management, with or without silendoscopy.
If you assess the stone and it's in that intermediate 4 to 7 millimeter range, the pathway branches off to either endoscopic removal or transoral ductotomy. And for stones greater than 7 millimeters, attempt transoral removal if it's palpable. But if you're dealing with a deep hilar or intraglandular stone, the algorithm mandates submandibular gland excision.
Finally, Section 6, FCPS Viva Pearls. Let's bring this explainer home with some rapid-fire, high-yield takeaways for your examiners.
Pearl number 1. What's the most common site? It's Wharton's duct, especially the hilar or proximal duct near the second molar region. Never forget that anatomical landmark.
Pearl number 2. Your first-line approach for small stones under 4 millimeters is always conservative treatment, with or without silendoscopy.
Pearl number 3. When you're dealing with palpable high-lid stones, the preferred treatment is transoral removal to preserve the gland. Gland preservation is key here whenever possible.
And the final pearl. You need to know your absolute indications for submandibular gland excision. You do this for intraglandular stones, deeply impacted hilar stones that are not amenable to transoral or endoscopic removal, recurrent stones with chronic sialadenitis, or a completely non-functional
Vascular neck mass?
Okay, so we're starting our anatomical journey right in the neck, specifically at the bifurcation of the common carotid artery. So what exactly is a carotid body tumor, or CBT? Well, it's a highly vascular paraganglioma arising from neural crest-derived cells, the chemoreceptors to be exact. Now, these are almost always benign, appearing in about 90 to 95% of cases, but they have some pretty fascinating risk factors. Surprisingly, they're heavily tied to chronic hypoxia, so if you live at high altitudes, your risk actually goes up. They also predominantly affect middle-aged female patients and can be linked to familial SDH gene mutations, which, by the way, often show up as bilateral tumors. So, how does this actually look in the clinic? Put yourself in the patient's shoes. They usually notice this slowly growing, completely painless swelling right in their neck. When you examine them, you'll feel a firm pulsatile mass, and because it's so incredibly vascular, you might even hear a brew. Now, as this tumor gets bigger, it starts crowding the local real estate. The patient might start complaining of dysphagia, trouble swallowing, or hoarseness, or just general neck discomfort. In really advanced cases, it can actually press on the lower cranial nerves, specifically cranial nerves 9, 10, 11, and 12, giving you those distinct nerve palsies.
Now, this next point is absolutely crucial for your exams. Fontaine's sign. When you palpate the mass, it'll gladly move horizontally, side to side. But try moving it up and down? No way. It won't move vertically at all. Why? Because it is literally tethered to the carotid vessels running vertically through the neck.
All right, let's talk workup. You might start with a Doppler ultrasound, but your absolute go-to, the investigation of choice, is a CT angiogram. This is going to beautifully light up that hypervascular tumor and show you the classic liar sign. That's when the internal and external carotid arteries are literally splayed apart by the tumor, kind of looking like an ancient Greek lyre. If you happen to order an MRI instead, watch for a classic salt and pepper appearance. And on histology, you're looking for that massive buzzword, the Zellballen pattern, which is made up of chief and sustenticular cells.
Moving on to Section 2, the Shambling classification, which helps us predict the surgical battle ahead.
Knowing exactly how tough it's going to be to safely remove this vascular mass is key. Enter the Shambling classification, which grades surgical difficulty based on vessel involvement. Let's look at the table. Type I is a small tumor that's easily separated, meaning an easy excision, nice and straightforward. Type 2 gets moderately difficult because the tumor now partially surrounds the carotid arteries. And Type 3? That is a surgeon's worst nightmare. The tumor completely encases the internal and external carotid arteries, meaning excision is very difficult and you will almost certainly need complex vascular reconstruction.
Let's lock this into your memory with a super quick mnemonic, the 3 I's. Type I is isolated. Type 2 is in contact. And Type 3 completely invests or encases the vessels. You've got to know this grading because it dictates operative blood loss, the risk of cranial nerve injury, and whether the surgical team needs to prep for vascular reconstruction.
All right, Section 3, the acoustic neuroma, or as I like to call it, the cranial nerve threat. Let's shift our focus way up to the cerebropontine angle, the CPA, to meet our second pathology, an acoustic neuroma, more accurately called a vestibular schwannoma, is a benign Schwann cell tumor. It sprouts right from the vestibular division of cranial nerve 8 in the internal auditory canal. And get this, it is by far the most common tumor you'll find in the CPA. Now, the clinical presentation here is a completely different beast from the neck mass we just talked about. If a patient walks in with progressive sensory neural hearing loss and tinnitus, that ringing in the ear, but strictly in one ear, an acoustic neuroma should immediately shoot to the very top of your differential diagnosis. That unilateral ear presentation is typically the earliest symptom as the growing tumor begins compressing the eighth cranial nerve.
And it's a real domino effect in there. As the tumor expands in that incredibly tight space, it knocks out adjacent nerves in a very predictable sequence. First to go is cranial nerve 8, giving you that hearing loss, tinnitus, and imbalance. As it bulks up, it hits cranial nerve 5, the trigeminal nerve. The high-yield sign to look for here is an absent or reduced corneal reflex, usually alongside some facial numbness. Finally, as a late-stage sign, it compresses cranial nerve 7, leading to facial weakness. And if it gets massively large, you're looking at cerebellar signs like ataxia or even raised intracranial pressure. To nail down this diagnosis, the absolute gold standard is an MRI with gadolinium contrast. This will brilliantly highlight an enhancing CPA mass extending into the internal auditory canal. You'll also want audiometry to confirm the exact nature of the sensory neural hearing loss. Now here's a massive can't-miss warning sign. Most of these cases are sporadic, right? But if you scan a patient and spot bilateral acoustic neuromas, stop right there. That is an instant diagnostic indicator for the genetic condition neurofibromatosis type 2, or NF2.
Okay, Section 4, comparing the two tumors.
It's time to put these two head-to-head and build that comparative framework in your mind. Take a look at this table. Origin-wise, you're looking at paraganglion cells at the carotid bifurcation for the CBT versus Schwann cells up in the CPA on cranial nerve 8 for the neuroma. Clinically, they're worlds apart. The classical symptom for the CBT is a painless pulsatile neck swelling, whereas the neuroma presents with progressive unilateral hearing loss. For classical signs, you've got Fontaine's sign in the neck versus an absent corneal reflex for the brain tumor. And to catch them, you'll want CT angiography as your best investigation for the highly vascular carotid body tumor. But you'll absolutely need an MRI with gadolinium to spot the acoustic neuroma.
And finally, Section 5, rapid recall for exams.
Let's shift gears into our lightning round. Treat this like mental flashcards. I'll give you the buzzword, you give me the diagnosis. Ready? Horizontal but not vertical mobility? Boom. That's Fontaine's sign, meaning you're dealing with a carotid body tumor.
Next up, you see a Lier sign on imaging as the vessels splay out, or you spot a Zellballen pattern on histology. Yep, once again, that is your carotid body tumor. What if you hear a surgeon talking about grades Shamblin I through 3? That's your specific surgical roadmap for predicting the difficulty of excising a carotid body tumor.
Okay, moving up the body. Progressive unilateral sensory neural hearing loss paired with tinnitus? That's the classic hallmark of an acoustic neuroma, the most common CPA tumor out there.
And the big one, what if a patient has bilateral acoustic neuromas? That's your absolute dead giveaway for neurofibromatosis type 2.
Here's the thought to chew on as we wrap up this explainer. Both of these tumors are overwhelmingly benign, yet their anatomical real estate makes them incredibly dangerous. You've got the neck's highly vascular crossroads, packed with major arteries and cranial nerves, pitted against the tight, pressure-sensitive confines of the cerebellopontine angle deep inside the skull. So what do you think? Which space poses the greater surgical threat? Keep that question in mind the next time you review your head and neck anatomy. Thanks for joining me on this deep dive into these two fascinating pathologies.